Morning, everyone. Hope everyone is good. Let me just get my controls back up. There we go. Can see everything now. Cool. How is everyone? Looks like we're live. Yeah, we've got a few people in the room, so that's good. Happy Monday again. Here we go. So episode 76. We're creeping towards that 100. We're going to have a look today. I started to put together. This session, and I was thought, you know what, we need to spend a whole session just on this region. So morning, Sarah. Morning. Just pop some messages up there. Good morning, everybody. So the way that I approach assessment of this region, and I can't. Morning, Tris. Good morning. Bit tired, hopefully up to no good. The way that I assess regions is if you kind of imagine the whole kind of circumference of that area. So if there's somebody has a problem in the lower back, sacroiliac joint kind of area, then I would kind of think of everything that is around that region. So that's the way we're approaching this kind of lumbar spine area. And we've had a look at the inguinal ligament before when we looked at the hip and the pelvis, but we're going slightly north of that now. So the attachments into the inguinal ligament. And there's a few times when I've said, is it inguinal or inguinal? It's potato. Is that right? Tomato. I'm going to say inguinal all the way through because that's what I usually say. So if you want to say something else, that's fine. We know exactly what you mean. It's different people say it in different ways. So we're going to focus the whole session on that. It's if you've not really done this this region before, it might be a lot new to you, and there are some of the abdominal muscles that you may have heard of before if you've done some level of anatomy. So what we're going to have a look at is if you think about that abdominal region, is that lower border. So that's just literally that line from your pubis all the way through to the ASIS. That's the bit we're going to focus on today. Good morning, Al. Good to see you, mate. Morning. Cool. So without further ado, let's get going. So the title was the inguinal ligament, but it's going to be inguinal ligament and inguinal canal. Good morning. Oh, we got a few in this morning. That's good. Because we've covered the ligament already, and what you'll find out hopefully today, if you didn't know already, is that there is a like a tube that is above that inguinal ligament, and I'm going to talk a little bit about the embryology of it and why both males and females have it. But it's usually more of a problem for males than it is for females, and we'll see why in a second. And but then whilst I was doing my research for this, found out some really interesting stuff, basically. So I'm gonna show you what I found. Good morning. Cool. We've got some diploma students on as well this morning. Cool. So if anybody has comes in with any kind of groin pain, and that this is a weird one as well. So even amongst males don't talk about males' problems. So I've had a few people come in and they say, "Oh, I've got a groin issue," and if you just left it there, you go, "Okay, cool. It's probably the adductors," but you need to question it a little bit further, and it depends on the kind of work you normally do and what they expect, because they may be a bit like, "Oh, well, didn't realize you were going to mention that." But basically, you need to, especially for males, you need to talk about whether there's any pain into the testicle, because that can be something where they go, I'm I'm kind of alluding to the fact that I've got a problem in that region, and I don't want to say anything. I'm going to call it the groin. Okay, so and you need to be quite specific. So and say exactly where it is, because if you do soft tissue work and that's what you've done in the past, then you can test all the muscles and you can do all the adductor tests, short and long adductors, and check the hip, all the kind of orthopedic stuff. And yeah, they may not mention it, and and in the back of their mind, I can tell you, they will be thinking that they have testicular cancer, and they kind of don't want to ask or don't want to say because they don't want that to be a possibility. But obviously we need to know. So it's questioning a little bit further. But the only way you can do that is if you know the anatomy really well, because otherwise it's like okay, because obviously it's not our remit to test those areas. They need to go to their GP. But if we can ask a few more further questions, and there are areas you can palpate definitely around this region, and you can be careful with where you're touching, then you can put someone's mind at ease, or if you're still not sure, you send them off anyway. Okay, so but we just need to ask those questions. I think, especially with I mean, there's a lot of quite rightly, a lot of focus on female health, but male pelvic health is an issue as well. We just do not talk about it. So hopefully this will give you a few things to chat to your male clients about. And in my experience, it has been those who are quite young, so late teens, early 20s, creeping up into the 30s, and I mean that's classic kind of age for those kind of pathologies. So yeah, if we can get a bit more confidence ourselves about that region, then hopefully we'll feel okay about asking some of the questions we need to ask. So let's have a look. So we've got the inguinal ligament that we've seen before, and we're going to cover that again. But what we're going to have a look at is this canal network. So if we think about the obviously living in Birmingham, we've got to talk about canals. So you've got this inguinal ligament that goes from the ASIS to the pubis, and what we're looking at is everything above that. Okay, so we previously what we've looked at is the femoral triangle, so where the blood supply and the nerve supply to the leg go underneath that inguinal ligament, and there is a gap, there's some openings there, and you can have some hernias in that area, and we're going to talk about hernias today. But they'd be femoral hernias rather than inguinal hernias. Okay. Morning, Julie. Good to see you. Welcome. Okay, so this is the canal. So um, it's really hard to draw this on a 2D page. All right, so I've tried to do all the arrows in the right place. So if to remember the inguinal canal and the areas that border that canal and make up the tube network, you can use the mnemonic MALT, M-A-L-T. So the M is to do with muscles. Okay, so the superior part, so the roof of the inguinal canal, is formed by these muscles, and we've not really covered them on this section, this part of Learn Anatomy Online yet. We will go into these in a bit more detail, but we're literally just focusing on the most inferior border of these muscles. So these muscles, if you've never heard of them before, these are ones that are they come from the back all the way to the front of the abdomen, and they form part of the abdominal wall. And the abdominal wall, those muscles, they attach into the inguinal ligament, and you'll see. So the inguinal ligament is the most inferior part of the musculature attachment. Yeah, so it doesn't attach into bone; it attaches into the ligament. So that and that's and it has to be that way so that things can pass through and pass under. Okay, so the superior part of this canal network is the internal oblique muscle and the transverse abdominis muscle. So if we have a look here, hopefully this will make sense. So this is the superior, so the roof part of the canal. And then anteriorly, so at the front, we have something called an aponeurosis. Now, an aponeurosis is a covering, and it covers it's a fascial covering that covers the muscle, and it's basically a piece of connective tissue. So the muscle is there, and then it has this layer of aponeurosis over the top of it, which then attaches the muscle to other things. Okay, and we'll see a video of it in a second. So the aponeurosis of both obliques, the internal and external oblique. So the external is more superficial, internal is deeper. These structures form the front of your canal, so the anterior aspect. So the ones on your belly, basically on the front of your belly. Then you've got ligaments, which is the L of Malt, and there are two main ligaments. So the inguinal ligament, which is what we've talked about before, that goes from your ASIS onto your pubis, and again we'll have a look at these in a bit more detail in a second. And something called the lacunar ligament that you may not have heard of before. Those ligaments form the floor of the canal, so they're on the inferior aspect, so down here. Okay, so that's the front, that's the floor of it, and then that's the top of it, so you've got muscles on the top, fascia, aponeurosis on the front. Underneath, so kind of wrapping around, you've got these ligaments that kind of suspend everything, and then on the back we've got tendons, and these are tendons of some of the muscles. There's a fascia called the transversalis fascia, and that sits on the inside, and again we'll see this in a second, of this muscle, the transverse abdominis. And the transverse abdominis, transverse means across, abdominis means abdomen, so it goes all the way around the abdomen like a corset. Okay, and that's the innermost layer of muscular tissue in that region. Okay, so you've got transverse abdominis, then internal oblique, then external oblique. So we've got those layers of tissue from deep to superficial. Okay, and the transversalis fascia is the fascia that covers the back, so the posterior aspect of the transverse abdominis. You're going to have to kind of get your head into a bit of a 3D space today. Obviously, I'll show you some images so you can get it a little bit clearer. But there's all these layers going on around this region, and then things going through those layers. Okay, so hopefully I'll be able to paint a picture for you in your head. And then there's another tendon called the conjoint tendon, and this is the tendon part of the internal oblique and the transverse abdominis tendons. So obviously the muscles have a tendon at the end, and these tendons join together, and they form the back wall. So this back wall here of the canal. Okay, so top muscles, front. Imagine it like a tube rather than a rectangle. It was easier to represent it as a rectangle rather than a tube, to kind of differentiate all the different sections. But the top part is muscles, front part wrapping around is aponeurosis, underneath is ligaments, and then on the back is tendons. So they're all wrapping around things that are going through that canal. Okay. Uh, well, hopefully everyone else has got sound. I've fingers crossed. But yeah, you'll have to watch that bit back. That was probably the most important bit. Never mind. But yeah, you'll have to enjoy my commentary later. Sorry, Al. Okay, let's go on to the next bit. Okay, so we're going to go through the different sections now. So that floor are the ligaments, and we've come across some of these before. So let me just move me out the way there. Yeah, so we've got the inguinal ligament. So that's from your ASIS, which is just there. And we've covered these on the pelvis, all the way down to your pubis, just here. So what we've been doing, we've been focusing on these, okay, these structures here that go underneath that inguinal ligament. We're going to have a look at something that goes over the top of that inguinal ligament today. Okay, so we've got these structures obviously have to pass through into the leg, so that the leg has a blood supply, has lymphatic drainage, and has a nerve supply. But there's also reproductive organs that pass over the top of that inguinal ligament that also needs a tube through to get things through. Okay, so that area there and the tube that comes through, which is what we're going to discuss a bit more today, those areas are kind of weak points, if you like, where things can go through, and that's where you're more likely to get some herniations around this region. There are obviously other areas where you can get a hernia as well, and we'll talk about what a hernia is in a sec. The lacuna ligament, if you've not heard of this before, this connects the pubis and the inguinal ligament together, and it kind of folds back on itself. So it's this bit here. It's like a little bit of a triangular ligament just there. So you've got the inguinal ligament there, and then there's a bit of fascia just here, which is the lacuna ligament, which kind of wraps back on itself. So this is the floor of your canal, which we'll see in a second. The canal rests on the top just here. Okay, so this is the floor section of the canal. Now, this is what goes on in there, and this is really cool. Actually, this is really interesting, because when we are an embryo, we're kind of undifferentiated cells, and there are a lot of things. It's like why men have nipples. We have no need for nipples, but at that stage when we develop them, you don't know whether you're going to be a boy or a girl yet. So we all develop them, and then obviously the reactions that happen and the hormones, because of the different chromosomes, will create a different cascade of events, whether you're a boy or a girl. So, and the same is true for this region as well. So we all have an inguinal canal. For males, it's an important passageway. It's a passageway through the abdominal wall. So you get from basically the inside of your guts through to the external environment. Okay, and it develops in both males and females, but in the males it's more important because of the testicles. Okay, so when you hear about testicles descending in children, basically this is where they go through. They go through the inguinal canal. They start on the posterior wall of the abdomen, and then there is a ligament. So that ligament there, and there's a ligament in males and females, and the ligament in males is attached to the bottom of the scrotum. And what happens is, because that ligament is attached to the scrotum, as the fetus develops and grows, it pulls the testes through the inguinal canal and then down into the scrotum, and that's how your testicles descend. Okay, that's where they come through. So there obviously has to be a tube for them to come through, and they basically push their way through the layers of the abdominal wall. Okay, and we'll show you how in a second. So as the body grows, the testes are drawn down into the scrotum because of the tethering to the scrotum. So it kind of follows that line. Now, this ligament is also present in females, okay, and it attaches to the ovaries and the uterus. But obviously, the ovaries don't descend; they stay where they are. And in the males, it attaches to the scrotum. In a female, it attaches to the labia majora. So and that remains intact. So the where it comes through, it's exactly the same pathway. So you have this canal network coming through, but in the female, you are left with just that ligament, and that's it. Okay, because the ovaries and the uterus stay within the pelvic cavity. But in males, because the testicles descend, they obviously then fill the scrotum, and that's between 25 and 35 weeks of gestation, towards the end of the gestation period. What also gets dragged with the testicles, it makes me feel a bit wincy when I use that description, actually, is something called the vas deferens, and this is basically your sperm tube. So you have this tube that attaches onto the testes when it's in the abdomen, and that gets pulled with the testicle into the scrotum, but the tube obviously stays in place, and this is where you produce your sperm. So the sperm is made obviously in the testicles, and then comes up that vas deferens, and then through into the penis for ejaculation. So that sperm tube is also being taken with it down into the scrotum. Okay. Also, what's taken with it, because the testicles need a nerve supply and a blood supply, is the neurovascular bundle. So in males, we have all of these tubes going down into the scrotum. With females, the only thing that goes through the inguinal canal, there is a nerve, but there's also the round ligament, which is the ligament that attaches the uterus to the pubis. Okay, so yeah, when we start to differentiate, that's when different things happen. But at the beginning, it's all pretty much the same. Okay, so that I just find all the embryology stuff just fascinating. So if you'd never heard of those kind of things before, that's what's going on. I've got some really cool pictures that I'll show you in a second as well with that. So I'm going to show a little bit of video and then just to get things in a bit of context, and then we'll move on to the muscles. So let's have a look at this. Okay, so fingers crossed these play this week. Yay. Okay, good. It's always nice when you press play and it actually works. So this is a right side anterior view of the pelvis. So your ASIS is somewhere under there, and your pubic symphysis is just here. So your pubic tubercle. Let me just move that out of the way. There we go. So pubic symphysis just there. So we've had a look at all these muscles already over the weeks when we've been looking at the pelvis. So let's now have a look at the top part of the inguinal ligament. Hopefully, yay, it is working. Phew, I thought it stopped again then. Okay, so your inguinal ligament, so that picture that we've just seen previously, is underneath here. So you can see the needle there is going underneath this bit of fascia. So that bit of connective tissue is the aponeurosis. Yeah, so that's that fascia that I was talking about at the beginning that forms the front of the inguinal canal. So you can see it's running all the way behind there. So it's continuous with it. Yeah, it's all the way through. So it attaches to the external oblique fascia or the external oblique aponeurosis. Okay, so that's where MOLT comes in from before. So there's your ASIS there, and it goes from there onto your pubic tubercle or pubic near your pubic symphysis. Okay, so that cut edge is that. Okay, so this is it intact. This is what it looks like in real life. So you've got your pubis here, ASIS around here, and then there is a line across here where the inguinal ligament will be. But can you see this fascia? Yeah, so this connective tissue covers all of that region and provides integrity for the front of the inguinal canal, so the front of that canal. Okay, so far, hopefully. Okay, so yeah, so that's your external oblique fascia. Yeah, and this just shows that it's continuous with what we call the fascia lata. And again, we've looked at this when we looked at the thigh. So the you've probably heard of the tensor fascia lata, the little muscle at the top of the hip around here. So that is literally the tensor of the white fascia. Now the white fascia, the fascia lata, think about white coffee lattes, then that wraps around the whole leg. Okay, so it's not just a strip of tissue, connective tissue, it envelops the whole leg. And then if you just took the skin off of a cadaver, it goes over the whole body. It's not in sections, it is continuous. So the external oblique fascia merges with the fascia of the thigh. Okay, and they both basically converge and come together. So we've got this fascial line here, that fascial line there, and they're all merging over that inguinal ligament. Okay, so that's the external oblique fascia, and then that's the inguinal ligament just there. Okay, that up there's your iliacus muscle. Cool. Okay, so we're starting to creep into the muscles now. So hopefully that gives you a bit better picture of the front of the inguinal canal. So let's go back to our PowerPoints. We'll start to add on the muscles. So the muscles form the roof of the canal coming through. Okay, so we're going to have a look at those. This is the transverse abdominis. So you can see the direction of the fibers is across the body and it's in the abdominal region. So hence why it's called transverse abdominis. It's more muscular here and then more tendinous here. What you may not have noticed before, if you've had a look at these muscles previously, is there is a gap just here. Okay, so the muscle attachment attaches onto the kind of first third of the inguinal ligament, but then it doesn't attach to anything else here, but then it forms that conjoined tendon here. So there is basically a gap. Okay, so inguinal ligament at the beginning, transverse abdominis attaches, then there's a gap, and then it attaches at the end. Okay, it's amazing how it all kind of comes together. So yeah, so it inserts, if we have a look here, linea alba, which means white line. So that's the line up the middle of your where the diastasis recti takes place. If you have a increase abdomen size, so can separate between rectus abdominis. So that linea alba is where your belly button is basically, and the transverse abdominis will knit into that that section there, and then it pectineal line of the pubis, so it will come right down onto here. Okay, but there's a gap in between. Yeah, so we're going to have a look at that in a second when we get to the dissection. So this is the innermost layer of the abdominal wall that we're going to concentrate on today. Okay, there are some other muscles, but we'll add those on at a later time. Then you've got your internal obliques, and your oblique just means kind of like in an oblique direction. Okay, and your internal obliques, they also attach, and again, you might have seen these before but not really noticed, they also attach on the first bit of the inguinal ligament, which is here, but there is a gap here. Okay, and then it attaches onto the pubis again. So again, we've got another gap, but what happens with the internal oblique? So transverse abdominis, let's say the gap is closer to the ASIS, then the internal oblique is slightly further along. So it's creating a pathway through the abdominal wall, but in layers. Okay, and you'll see that when we come to the dissection. Right, let's have a look at that. So just go back to there. Here we go. So hopefully we're going to add on the muscle layers now. Yeah, so there's your lacuna ligament. So we talked about that right at the beginning. So that's that one just there. Yeah, it shows you that image before. So this is the floor of the inguinal canal. So the lacuna ligament is that one just there. It's a nice smooth transition. Okay, so that's just here. Okay, so you can see it just there, and that's that bit just there. So it's kind of folding back on itself, and it attaches on that line just there. Okay, so this forms the floor of the canal. So all along there, this is where your attachment's going to be. So transverse abdominis and your internal oblique attach here. So this is what I was saying before. So there's your transverse abdominis attaching all the way along that first bit of the inguinal canal, inguinal ligament, and then there's a gap. Oh, just moved the wrong picture. And then there's a gap. And then there's your internal oblique. So this is the next layer. Attaches all the way along there, but a little bit further down. And then there's a gap. And you can see the gap just there. Cool. Oh yeah, let me just pause that there and go back a second. So let's have a look at that again. So internal oblique attaching there. Then there's that little gap, so you can see it just there. And then that bit there, if I just pause that, that's where they rejoin again. And that's where that conjoint tendon is. Okay, so that conjoint tendon, internal oblique, transverse abdominis, there's a bit of a gap, and then it attaches onto the linea alba, so that middle part. So there's basically a hole here for things to pass through, but it's all in layers, and I quite agree. When I was doing the research on this, I was just like, this is just amazing. Right? It's so good, and it makes sense why things go wrong. Okay, so yeah, it attaches onto here. So there's your external oblique, which is the final layer that goes over the top. And if I just pause that there, you can see, can you see that little kind of crescent shape there? So this is the first opening to the outside world from the internal structures, your internal abdominal cavity. So it will travel from around here. So it's kind of, there are two different rings, and we'll talk about that in a sec. So the first one comes from around about here. Then the canal travels down here, and then the outer ring is here. Okay, and then out pops round ligament in females, or the spermatic cord in males. Okay, so that external oblique fascia wraps around whatever comes out. Okay, so we should, there we go, and there's all the fascia on top. So look at it, all connected. There's your inguinal ligament line, and there's the opening just there. Okay, I'm just going to pause that there. Cool. So that's where we are at the moment. So now we're on the anterior part of the inguinal canal. We're on the front of it, and this is the this muscle here is your external oblique, and this is the external oblique aponeurosis. Okay, so that's the A part of MALT. Yeah, so the aponeurosis is anterior, which makes it a bit easier to remember. So that is this bit. Okay, so let's have a look at that. So the external obliques, and again, you might have seen this image a million times and just think, oh yeah, I have to do crunches with a twist to activate these muscles. You might not have noticed this little gap here. Okay, and that is where things come through. So we had transverse abdominis, deepest, then we had internal oblique in the middle, and then external oblique, more superficial, so towards the outside. And each of those layers has a different attachment on the inguinal ligament at different stages so that things can pass through. Because obviously, if you imagine that everything all had a hole here, then it would just come out. Yeah, so there has to be stages at which things will pass through, and when there is a defect in that inguinal canal, that is when things when they come out. Okay, that would be a nice. I can just imagine someone just screenshotting that. I've got to be careful what faces I do. So the tendons, then we've had a look at these. This is the back wall, the posterior aspect, and we had a look at those just a second ago on the video. So we've got the conjoint tendon, and this is the conjoint tendon of internal oblique and transverse abdominis. Yeah, so we've got both of those muscles converging together to form the back wall and then attaching to the linea alba, which is that white line in the middle. Okay, and so that's that bit there. And so again, we've got attachment here, gap, attachment here. Yeah, so hopefully that kind of makes sense. So we've kind of looked at these already, but not give it. Well, you've seen the name of one, but not really explored it. So let's go into this. So on the inside of your abdominal wall, you have the first opening where things come through. Okay, and that is called the deep inguinal ring. So the deep inguinal ring, if we have a look at it here, so these are the different layers of tissue. So you've got fascial layer, then you've got transverse abdominis, then you've got internal oblique, then you've got external oblique just there. Okay, and if you, let's have a look. Yeah, so deep inguinal ring is just there. Okay, so you can see the vessels or the ligament that comes through it comes through that transversalis fascia, through transverse abdominis, through internal oblique, traveling down along the inguinal ligament, and then popping out here either into the scrotum or labia majora if it is the round ligament. Okay, so that's the pathway of things. That's where they come through. These vessels here, not to be confused, these are your femoral vessels. These are the ones that go underneath the ligament. Okay, so you can see them popping out here. So this bit here is coming out over the top of the inguinal ligament. These ones here are coming out underneath it, and we've already looked at those. So the deep inguinal ring, this bit here, this is the entrance to the inguinal canal. This is where it first starts. it's in line with the middle of the inguinal ligament. So if you put a finger on your ASIS, a finger on your pubis, halfway between the 2 points, that's where your deep inguinal ring is. Okay, and if someone has a hernia, there are different types of hernia. We'll cover those in a sec. That might be the first point where it comes through. Okay, so it's just something to bear in mind when you're listening to people's stories. So there is an opening in the transversalis fascia. So this is the fascia that's deep to the transverse abdominis, and you can see that here. So there's your TVA, your transverse abdominis, just there, and then that's the fascia behind it. So it lines the inside of your transverse abdominis. So, and that's the first thing it pierces. It comes through there. Okay, so that's the deep inguinal ring. Then we've got the superficial one, and this is the one that's more anterior, so more towards the front. Okay, and this is the differences in males and females. Just try and move me out of the way here. There we go. Okay, so this is a female, and you can see the uterus and the ovaries here. So you have the ovary ligament and the round ligament that come along through the deep inguinal ring, along the canal, and then out of the superficial ring, and then attaching by the labia majora. Okay, so you can just see it faint on that picture there. Okay, so if you've never seen it before, never heard of it before, have a look up round ligament of uterus. Okay, and I've got some other good images in a sec as well. In males, there's a bit more going on in this region. So you have the spermatic cord, you'll have the nerve supply to the testicles and that inguinal region. You'll also have the vas deferens, so the tube coming back out for sperm production will come through this region as well. But that's where the spermatic cord will come through. So that superficial ring just there. So this is an opening in the external oblique, so the most anterior structure, the most superficial structure, the opening for the spermatic cord in males and the round ligament in females. Okay, so it's just lateral to the pubic tubercle. And whenever I've had somebody who I've thought has had a hernia, you are nowhere near intimate areas palpating this. Obviously, if you've not done it before and no one's ever shown you, then don't go practicing on your patients. But there are certain ways that you can assess this region, and you can do it in a way where it's where they feel entirely comfortable. And I managed to pick. There was a guy who was really freaked out. Didn't tell me about testicular pain, but he had it, and it was only when I investigated a little bit further because he thought it was like a sportsman's hernia, so basically an adductor issue. And when I palpated the pubic tubercle, he nearly hit the roof and it reproduced his symptoms. So we sent him for a scan and he had a hernia. Okay, so and the three people that I've done that examination on, they've all had hernias. So it is something that you will probably see if you're dealing with, well, blokes basically, and especially if they're quite active. Okay, so just something to keep in mind. So that's your superficial inguinal ring. So that's the bit we've just seen on the video here. Okay, so that's where it all comes through. So let's have a look. Let's build a little bit more on there. So that this is where the spermatic cord or the round ligament comes through. Obviously, it's not an opening like that in real life. There are things that are attached to it, and we'll have a look at that as we go through. So there are these little crosses, so bits of connective tissue, and they attach just here. Okay, so they basically form an opening. So we've got kind of like a canopy that attach onto the pubic tubercle where things can come through. Yeah, so you've got the covering of the external oblique, and then you've got these kind of bits of connective tissue as well called the crus, which kind of circle around that opening to give it more integrity. And that attaches right on the pubic tubercle, and that was where that guy was right there. So there's your fascia, and that's the pathway of it. So it goes there, and then it tucks underneath your internal oblique, underneath your transverse abdominis, and then pops out just through there. And that is the start of your deep inguinal ring. Okay, so that's your inside of your transverse abdominis. Obviously, they've taken away some fascia here, but there'll be fascial covering of this area, and there'll just be a small opening there. That's obviously quite large because everything's been taken away. But that's where your deep inguinal ring will start. Okay, and then this is the spermatic cord. So there's the superficial ring there, and then these are the structures that come through. So there's the neurovascular bundle, so the blood supply for the testicles, and then there's your vas deferens. So that will come from the testes out of the inguinal canal and then towards the penis, and that's where your sperm will go. Okay, so there's the deep inguinal ring just there. So you can see it's a bit more covered on that one. So you can see it passing through those structures there. There's your pubis. Yep, so testicular artery and vein, and then vas deferens just there. Cool. So that's it, and we're going to have a look at the layers. Go back on now. So that obviously the spermatic cord isn't free like this. We've got everything's connected. So you've got fascia around the spermatic cord. You've also got a muscle attachment, which we'll see in a second. So there's your internal oblique. So it's coming out underneath there, and then you've got another muscle. There you go, which is called the cremaster muscle. You'll only have this if you're a male. We've got one extra muscle, and this, if you remember, I always remember back at school where you hear about sumo wrestlers being able to lift their testicles back into their body, and that's the muscle that will do it. That's your cremaster muscle, so it will lift the testes up. Okay, so and there's a cremasteric reflex that you can do to test the reflexes of that muscle, and it's on the inner thigh. You just basically stroke the inner thigh, and then your testicles will go up towards your abdomen. Okay, one for you to try at home. Okay, so there's the external oblique, and then that wraps around the spermatic cord. There aren't any cadaveric dissections that I've found of the female anatomy, which is really common, unfortunately. I found some stills. I'll show you the images, but yeah, nothing like this, I'm afraid. So this is the intact. Move the wrong one again. This is the intact oblique aponeurosis. Okay, external oblique. So you can see it wrapping around. Yeah, so everything there's no holes anywhere. Everything's all continuous with each other as it passes through. Okay. And I think I've just messed up the video. I think that's about it anyway. Yeah, I think that was the end. Cool. Okay, let's have a look at that. Cool. So that's what we've just seen there. So in females, obviously the round ligament comes through. In males, it's the spermatic cord just there. And this, again, this is a really nice image actually of the differences. So you can see that all the different layers and then the structures that pass through. So in the female, you've got the nerve supply and then the round ligament. In the males, all of the supply for the testes, plus the nerve, plus the blood supply, plus the vas deferens. So this is why inguinal hernias are more likely in males because the gap, the hole is wider. Okay, so that's why we usually have them. So these were some of the images that I found of the round ligaments. There's the uterus, and you can see the round ligament. It's really small writing on there, but that's it just there. So you can see it kind of attaches onto the just underneath the fallopian tubes through that deep inguinal ring, out of the superficial inguinal ring, and then attaches onto the labia majora. And obviously in the male, then that would be connected onto the scrotum. So that's your round ligament. This is what happens when you're pregnant. Okay, so the round ligament gets really stretched. Okay, which is entirely normal, but you may have like pubic symphysis discomfort with that stretching of the round ligament. Might be one of the reasons why you get a pubic symphysis issue. And then lastly, what time are we? Perfect, good timing. So the different types of hernia. Obviously, like I said at the beginning, there are loads of different hernias that you can get, and we'll cover these as we go through the abdomen region. But in this particular region, you've got indirect or direct. So this is normal. So all of the musculature in place. We've got the inguinal canal, and everything is as it should be. If you've got an indirect inguinal hernia, what will happen is part of the guts will go through the deep inguinal ring, and it will start to travel along the inguinal canal. And in extreme circumstances, it can emerge into the labia majora, so that basically it will look enlarged on that side of the genitalia, or down into the testicle. So you basically end up with guts in your bits. Okay, so that's what a hernia is. So that's an indirect one. A direct one is usually when you're a bit older and the abdominal wall is weakened. So this hasn't gone through the deep inguinal ring. It's actually pushed through the posterior wall of the inguinal canal, because there's been a weakening of the abdominal wall, and the guts go into the canal through the wall rather than through the ring. Okay, so that's the differences between the two. We wouldn't necessarily know the differences in terms of someone coming into clinic. They would need to be assessed properly, but those are the different types of inguinal hernia that you can get. Okay, cool, and that's it. All done. That's a bit of an overview of the inguinal ligament, the different types of pathology in that region, and there are no questions, so kind of stunned silence. So I hope that was useful for you, and another kind of thing to think about if you have anybody who's got pain around that region. And it's obviously useful to know the structures of that region so that you can do an assessment. Okay, so hopefully that was all good, and that's all right. You're welcome. Hi, Becky, and I haven't answered your question, Becky. I haven't had a chance to look yet, but I'll have a look today for you. No problem, Sarah. Yeah, good to have you in on the Monday morning again. Brilliant. So I'll see you next Monday at 10 o'clock. See you then.